Social Anxiety, an audio-visual presentation created by Daniel Prasad and Charlene Blanchard.
So, what are we covering, or what can you expect to get from this presentation? Well, first we will explore what anxiety and social anxiety is, and how it is experienced. After, we will talk about how it's diagnosed and differential diagnosis. We will then look at epidemiology, answering the question who it affects, and to what degree it's prevalent in Canadian and world populations. We will then try to provide some insight into how social anxiety can be treated by looking at cognitive models of treatment as well as behavioral techniques from the CBT approach.
What is social anxiety?
What is anxiety? Some explain anxiety as having two dimensions to it: the internal feeling of distress that one feels, and the physiological changes that come with it. That is to say that the mind and body are intrinsically connected when it comes to anxiety. In fact, many people who report having anxiety disorders also present with physical symptoms such as insomnia, IBS or irritable bowel syndrome, chest pain, headaches, sweating, and other symptoms for which other medical explanations cannot be found. When a person experiences anxiety, hormones such as epinephrine and norepinephrine, also known as adrenaline, are released, which cause a physiological response. Often this physical response looks like an increased heart rate, higher blood pressure, and increased muscular tension. If you're anything like me, you'll find yourself clenching your jaw with elevated anxiety. However, it should be noted that not all anxiety is bad. Some anxiety serves an adaptive purpose. You can think of the anxiety you might feel when trying to maintain a friendship, causes you to reach out and spend time with that friend. Or anxiety around an upcoming test or paper. It might encourage you to work a little bit harder, a little bit sooner. The challenge with anxiety is when it becomes extreme, and one such extreme is the experience of social anxiety. We'll find out more about what social anxiety feels like and the diagnostic criteria to be diagnosed with social anxiety in the next slides.
Say it's your first day at a new job. Maybe you're nervous or jittery. You want to make a good impression. Those feelings are pretty normal, and they may actually help you be more alert and careful. But after a few weeks, once you're used to the job and you know your co-workers, that nervousness usually diminishes, right? Well, for some people, that initial anxiety is really high and it stays really high over time. For those people, the fear of being judged negatively by new people might be so daunting that it affects their ability to do their job well. In fact, even the idea of having to be somewhere where they may be scrutinized by others might make them not want to do the job in the first place. This describes social anxiety disorder.
What does social anxiety feel like? This video shows a young woman's lived experience with social anxiety.
Fear. She's rude. You're overreacting. It's not a big deal. She's so stuck up. Nobody understands what it feels like. It feels like wanting to compliment someone but being too afraid. When it's Saturday night and the only place you want to be is in bed. Every conversation and every laugh you hear is about you. When your teacher tells you to find a partner and your heart sinks. Panic attacks in the school bathroom, constantly feeling judged, continually being sick to your stomach, bailing on plans last minute, worrying about being annoying, and overthinking every little thing. Going home at the end of the day is my escape. It's my safe place, somewhere I cannot be judged. It's a weight off my shoulders for a short period of time, until I do it again the next day.
What is the diagnostic criteria for social anxiety disorder? According to the Diagnostic Statistical Manual, DSM, Morrison, 2014, describes that to be diagnosed with social anxiety disorder, there must be an excessive amount of anxiety and fear that surrounds situations where other people could hypothetically be watching that individual. These situations are where people, for example, could be speaking in public, drinking or eating, talking in front of a crowd, or even just to one other person. These situations typically make someone who has social anxiety feel a great amount of rejection and embarrassment, so much so that the individual tends to avoid such situations in prevention. Morrison continues, stating that for children to be diagnosed, others must also be a fear of their peers' reactions as well as adults. To be diagnosed, a person must experience the above-mentioned symptoms for more than 6 months with impairment to social function such as work or school. Other disorders that share similar symptoms are substance use, mood and psychotic disorders, anorexia, OCD, avoidant personality disorder, normal shyness, and other anxiety disorders. Morrison specifies that the DSM states to code the diagnosis if the client experiences fear of public speaking or performing, but not in other experiences. This slide shows an assessment published by the American Psychological Association, created by Kraske et al. 2013, to be used as a measure in an intake and to monitor treatment. This assessment is used as part of a toolkit, not to be the only factor in making a clinical diagnosis. These 10 questions assess the severity of the symptoms related to having social anxiety disorder after the individual has received their diagnosis. It asks the client to rate each of the items for how they have felt over the last 7 days. The total score can range from 0 to 40, with a higher score meaning greater severity. The clinician calculates the average total score, which reduces the score to a 5-point scale to easily continue to measure the client throughout treatment. Questions asked are: 1. Felt moments of sudden terror, fear, or fright in social situations. 2. Felt anxious, worried, or nervous about social situations. 3. Had thoughts of being rejected, humiliated, embarrassed, ridiculed, or offending others. 4. Felt a racing heart, sweaty, trouble breathing, faint, or shaky in social situations. 5. Felt tense muscles, felt on edge or restless, or had trouble relaxing in social situations. 6. Avoided or did not approach or enter social situations. 7. Left social situations early or participated only minimally. 8. Spent a lot of time preparing what to say or how to act in social situations. 9. Distracted myself to avoid thinking about social situations. 10. Needed help to cope with social situations. Who does social anxiety affect?
Social anxiety disorder is widely considered one of the most common anxiety disorders, and even one of the most common psychiatric conditions, behind depression and substance abuse. Lifetime prevalence rates of social anxiety disorder range from 3 to 13.3%, according to Milkert and Caldwell. The 12-month prevalence rates from the APA puts the number of Americans affected at approximately 7%, but it's a little bit lower for the Canadian population at 6.7%. In a very recent epidemiological study by Stein et al., they found that the prevalence rate of social anxiety was 1.9 to 13.7%. And this is in a study that included 142,000 individuals across 28 countries. Interestingly, Stein et al. Found that the following factors were associated with social anxiety. These factors included younger age, female gender, which was in contrast to the APA's finding that it was more common in male clinical populations than female clinical populations. Social anxiety was also associated with unmarried status, lower education, and lower household income. As mentioned in the previous slide, social anxiety disorder is associated with a young age. The median onset of the disorder is 13 years, where 75% of all individuals with social anxiety disorder experiences the onset between ages 8 and 15. Also mentioned earlier, social anxiety disorder has to be differentiated between normative shyness. But the disorder has shown to emerge out of such shyness, and social inhibition usually establishes a foothold after a stressful or humiliating experience. That's reported by the APA and the DSM. Assessing for social anxiety at various stages can present some challenges. For adolescents, underidentification may occur because young persons often minimize their challenges, and it's consistent with the negative evaluation or the fear of negative evaluation that comes with the disorder. In later adulthood, detection is challenging because of a lack of insight that may be caused by changes to social environment or roles that might obscure some of the overall challenges that they may be facing.
What maintains social anxiety? Hedman and colleagues have compiled research on the association of shame and guilt in relation to social anxiety. They state that from an evolutionary point of view, social anxiety can be thought to have developed to assist the individual in avoiding behaviors that would put them in a position to be left out of the community, which is perhaps why social anxiety is described as a fear of exclusion from others. Shame can be defined as a feeling where an individual perceives others viewing them in a negative way, thinking that they have negative characteristics, or feeling as if one has engaged in behaviors that are disgraceful. This is made possible by the mind's ability to speculate how they are being viewed by others. It is believed that the evolutionary purpose of shame is to promote behaviors that are attractive to others. Shame and guilt are different in that guilt mostly is unrelated to what others think, and more so focuses on how one's specific behaviors infringe on others from one's own point of view, and promotes regret. Alternatively, shame is perceived attractiveness and is pointed at the self rather than to explicit behaviors. Shame can be external or internal. External shame is the feeling that is created on how one is looked at by others concerning one's behaviors that make someone feel rejected or criticized. Internal shame is how someone views themselves when we are both judging and the object of that judgment. In cognitive models, as quoted by Hedman and colleagues, a core feature of social anxiety is the strong desire to appear favorable to others, but believing that one is incapable of doing so. The individual believes he or she is perceived by the audience, and that social anxiety occurs when one makes a judgment that one fails to meet the demands of others. Models of social anxiety are similar in nature to external shame, developing from the belief that one is unappealing to others. Cognitive models of social anxiety underline the importance of how one is being looked at by others rather than having a negative self-evaluation, which is more in line with depression. A social anxiety diagnosis does not necessarily mean that the individual thinks of themselves as insufficient overall, but rather to specific feared social experiences. Hedman and colleagues' study found that both internal and external shame was reduced, along with other social anxiety symptoms, with cognitive behavioral therapy. Kennerly, Kirk, and Westerbrook, 2017, described the following cognitive models for maintaining behaviors for social anxiety. Perceived social danger is when the individual makes predictions and assumes a negative outcome before a situation happens, such as thinking, if I talk to that person, I will sound stupid and be humiliated. The socially anxious person fears the possibility of negative judgment in the future. This can also be similar to a self-fulfilling prophecy. Self-focused attention creates a powerful cycle that is fueled by extreme self-awareness that is difficult to break away from. Because of the focus on the self, the socially anxious person is somewhat removed from reality and not able to handle real-life situations. Their mind becomes hyper-focused on themselves, causing distortions when attempting to read the reactions of others. Emotional reasoning is similar to self-focused attention in that the individual also becomes hyper-aware, but in this case it's of the body. Physical sensations of anxiety and embarrassment, such as one's face going red or hands shaking, magnify. People with social anxiety can become fearful of these tells of their anxiousness and are terrified that others may see these reactions and will judge them in a negative way. Safety-seeking behaviors are developed because at one point they provided the socially anxious person with relief from negative emotions, but maintain social anxiety as they typically backfire once repeated and make a person look odd, which fuels social anxiety. Examples are avoiding eye contact, sitting in the back of a room, or asking excessive questions as to not focus on the self. Figure 6 shows how these developed thought patterns work in a loop because of beliefs going unchallenged. These individuals do not learn that the catastrophe does not happen, which maintains the behaviors and resulting social anxiety. How do you treat social anxiety in a therapeutic setting? Cognitive behavioral therapy for social anxiety. Dayoff, 2013, describes that cognitive behavioral therapy, CBT, works as a treatment for social anxiety disorder by assisting the client in restructuring thoughts and learning new cognitive strategies that assist clients in challenging the fearful thoughts, beliefs, and maintaining patterns that were discussed in the previous slides. The behavioral component is derived from learning theory, focusing on what can be observed. The aim of CBT is to impede or eliminate maladaptive behavior. During the CBT process, Dayoff states that assessment is a continuous component, promoting clients and therapists to ask 1. What behavior is maladaptive? 2. What in the environment either maintains this undesirable behavior or reduces the likelihood of you performing a more adaptive behavior? 3. What environmental factors can you manipulate to alter this behavior? Kennerly, Kirk, and Westerbrook, 2017, lists 3 CBT-oriented interventions for social anxiety, which addresses the maintaining cognitive processes and cognitive models discussed in the previous slides. Refocusing attention away from introspection. This technique addresses the hyper-focus on the self that people with social anxiety experience. To do this, a therapist can assist their client in session to learn such coping strategies such as mindfulness training or grounding exercises. For example, listing 5 things you can touch, smell, feel, etc. These exercises help a client to look outward opposed to inwards, focusing on differing sensory inputs. After the client becomes comfortable in session, the therapist can guide the client to practice between sessions to improve skills. Developing an assertive or compassionate inner voice. Assisting the client in learning and developing self-kindness and compassion is a technique that addresses the internal dialogue of unforgiving criticism and shame that people with social anxiety typically experience. Engaging with the client in exercises that promote empathy and can reframe this inner voice are helpful, such as asking how a client would respond to a friend, or simply assisting clients by promoting reaffirming thoughts such as, "It's okay that I feel what I'm feeling. I'm working at building my confidence, and change take time." Cognitive reevaluation. Techniques that assist the client in having another perspective on thoughts and patterns that have developed into safety-seeking behaviors, as well as into perceiving social danger and experiencing emotional reasoning about negative judgment from others. For example, the therapist can model what it looks like to blush and sweat in public and have the client gauge others' reactions to this. Other examples of using cognitive reevaluations can be watched through the following links. The first video shows an example of a behavioral experiment where the client is filmed and then safety-seeking behaviors are discussed and reframed. The second video depicts a technique called the downward arrow, which is similar to Socratic questioning. The therapist also engages the client in a visual thought-challenging technique by the client finding evidence for and against presented core beliefs. Kennerly, Kirk, and Westerbrook, 2017, list a series of questions. Are the symptoms you fear actually as likely to happen as you predict? Even if they do happen, will it actually be as severe as you imagine? Even if it is, will other people actually notice? Even if they notice, will they interpret it in the way that you fear they will? Even if they do see it that way, so what? Is it possible you can survive it and get on with your life? This is a type of questioning used in such techniques as downward arrow and Socratic questioning, which are used as effective ways of assisting a client in being able to identify core beliefs and associated negative automatic thoughts.
Now we're going to explore some behavioral strategies. Edelman 2006 argues that while cognitive interventions are useful when addressing cognitions that arise in specific scenarios, exposure is a great intervention for regular or ongoing fears such as social anxiety. Her golden rule is that when it comes to anxiety, avoid avoidance. Exposing ourselves to things that we are afraid of enables us to discover that they are not so bad after all. To start with, the therapist will generate a list collaboratively with the client about what might be the most anxiety-provoking to what might be lower on that list of what might be anxiety-provoking. For example, a person who may have a fear of ordering a coffee at a shop may put talking to the barista and actually ordering that coffee at the top of the list, while merely walking by the coffee shop is anxiety-provoking but ultimately manageable. Graded exposure works from the manageable to the top of the list. Edelman proposes the following secrets to successful exposure. The first is repetition, and she really advocates for the daily repetition of seeking out these anxiety-provoking states and practicing that they're not so bad after all. The second is duration. And she would argue, don't dip your toe in and run away. To stay in the feared situation as long as necessary for the anxiety to diminish. If you could recall back to the physiological responses of anxiety that we had previously spoken about. It's about staying in that long enough for those to go down. The third is the challenge. So this is where the graded part of the graded exposure comes into play. Sometimes clients will agree to a manageable situation and say, oh, wow, I'm better now. It's important to make sure that the challenge is ramped up until you get to the top of the list. And that's why it's important to do those visioning exercises at the beginning. And lastly, look for spontaneous opportunities. So this will be opportunities for the client to take this on in their own day-to-day lives. If they're walking past a coffee shop, you can challenge them to walk a little closer or take a step inside and see how it is for them, so that they can prove to themselves that their fears aren't so bad after all. While exposure can be a great technique to get dramatic and lasting results, it is important not to rush clients into it unprepared. Some consideration on their readiness level and their ability to moderate the experience is important. As mentioned in the previous slide, exposure through imagery is a great way to work up to the in vivo or real-life experience. Another great way to get clients feeling ready for exposure is through relaxation techniques. There are many, ranging in complex solutions such as progressive muscle relaxation to simple breathing. Progressive muscle relaxation takes multiple minutes as you systematically relax the major muscle groups. Meditation is also a popular mechanic, in which one releases usual thinking patterns in lieu of experiencing inner stillness, passively releasing thoughts that arise in the process. Calming visual imagery can be helpful for the right person as well. It invokes peaceful imagery to expel physical arousal. For example, imagining worries floating away on a leaf, floating briskly on a river, all the while taking in the scent of the damp, sweet moss from the riverbank. Breathing exercises are also a great tool to practice on the run, on the commute to and from work, etc.
This video introduces an alternative approach to therapy for social anxiety using virtual reality as an integrative tool and learning platform for client and therapist to engage with.
It looks like a video game, but this is actually a high-tech classroom, training the brains of shy teens like Jeff and Charlotte to be more social.
I've learned how to start a conversation and just how to break the ice.
You're more confident?
Yeah, because normally I'm not like that.
Call it the Teen Socialization Lab, based at the Center for Brain Health at UT Dallas. It's run by cognitive neuroscientist Dan Krozik.
A lot of the skills that we need in life link back to the brain.
His virtual lab designed to help kids overcome social anxiety, aggression, and bullying. Do you find the kids that come in here are in many ways more comfortable in a virtual world than the, quote, real world?
I think it does make that more appealing and less threatening, especially with individuals who are anxious socially.
All right.
Here's how the program works. First, kids have their social skills tested.
A lot of different emotions.
Then, they enter the virtual reality lab, where their avatar faces social challenges involving other kids and adults. Jeff, a college freshman with mild Asperger's, struggles with new social situations.
I have a hard time of putting words and ideas together easily, as other people do.
So today, he's conversing with a new roommate.
Have you gotten classes all settled?
His counselor next door coaching him through it.
That's a good sign from him.
Pausing and replaying the interaction until he does better. The program is 10 half-hour sessions over 5 weeks. Jeff says he feels socially confident for the first time, even in a network TV interview with me.
We hope you enjoyed our presentation and learned something new about social anxiety and the various treatment options in a therapeutic setting. This presentation will conclude with a few questions and answers.
So the question is, my client and I are doing great in session when we utilize exposure, but all the gains made from our session are lost in the next session. How can I improve this? In CBT, our aim is that clients can be their own therapist. The key here is that clients can practice the skills on their own that they learn in therapy. If you're utilizing exposure in a safe and effective way already with your client, perhaps you can utilize some homework activities. An exposure schedule can help. Here you track which activities are done, how many times, and for how long. Remember Edelman's 2006 Secrets for Successful Exposure. Daily practice is important, and looking for spontaneous opportunities to confront your fears can also be very helpful. So the next question. Thanks for the answer, but I worry about the client doing in vivo exposure on their own still. What can I do? Well, thanks for the question. Exposure through imagery can be a useful tool for this. When given our full attention, imagery can become quite powerful, so it's important to instruct your client in some of the relaxation techniques before they do this on their own as well. With visual imagery, you just want to spend some time being there. In that situation, that can be fearful. Evoking sights, sounds, smells, and other sensations. You can use visual imagery to expose yourself to an event and create positive associations with it. You may agree with your client if this is a good option to practice the behavioral intervention away from your office, and how often that practice should occur.